So we're going to talk here more in detail about the drugs that are used in congestive heart failure. The USMLE does like to ask questions about specific drugs and adverse effects, so I like to emphasize the different drugs that we use in different disorders. If you haven't watched the slides on congestive heart failure yet, you should probably watch those, because I'm not going to cover too much of when we use the drugs. I'm just going to cover the drugs in general. So recapping how we treat congestive heart failure when we use these drugs. When the patient comes in and we diagnose them with congestive heart failure, which is usually done on chest x-ray, we will give them IV ACE inhibitors and IV loop diuretics. That will lead to the quickest resolution of symptoms. We're also going to give them nitrates or IV nitroprusside, oxygen, and morphine, and those are just supportive care. Inpatient management, so once we get the patient into the hospital, we're going to transition them from IV ACE inhibitors onto oral ACE inhibitors, from IV loop diuretics to oral loop diuretics. We're going to also start a beta blocker. That's going to be really important in decreasing mortality. We're going to continue their nitrates, oxygen, and morphine. And if their chest x-ray indicates a congestive heart failure that's systolic in nature, then we're going to have them on dobutamine, which is our positive inotrope. Once we get the patient out of the hospital, our outpatient management is going to continue ACE inhibitors, loop diuretics, and beta blockers that we had them on in inpatient care. As usual, we can always substitute an angiotensin receptor blocker with an ACE inhibitor. That's fine, but ACE inhibitors are going to be your first drug of choice unless the patient has had an allergic reaction in the past or has had an adverse reaction and they request angiotensin receptor blocker, or if it's anywhere on their history that they tend to do better on the angiotensin receptor blockers. So what we look for in ACE inhibitors we'll talk about on the next slide. So nitrates, will also continue that on the outpatient management. We give them nitroglycerin and or isosorbide. We never give isosorbide alone. We give nitroglycerin or nitroglycerin plus isosorbide. Spironolactone can be used in addition to all of this if all else fails. So if they're on this management and they're continuing to have symptoms, we can add spironolactone. So the overall strategy is going to be to reduce the pulmonary capillary wedge pressure. That's going to reduce our congestion in the cardiopulmonary system. Because remember what congestive heart failure is it's congestion in the cardiopulmonary system for one reason or another. And so what we want to do is we want to get blood out of the cardiopulmonary system. And there's many ways to do that. And they're all related to each other because they all get blood out of the cardiopulmonary system. And so one way we can do that is to increase our stroke volume directly. We can also increase our left ventricular ejection fraction, which is pretty much doing the same thing. We can reduce systemic vascular resistance, which will reduce the pressure the heart has to pump against, and that will physically get more blood out of the heart. And then we can also increase the contractile force of the heart. All of these are going to reduce pulmonary pressure and alleviate some of the acute symptoms of congestive heart disease. So the ACE inhibitors we tend to use most are captopril and lisinopril, but really any ACE inhibitor will be the right answer. ACE inhibitors are allosteric inhibitors of angiotensin converting enzyme. So what that means, being allosteric, means that it inhibits the enzyme itself. It doesn't block a binding spot. It actually blocks the enzyme from working. So this angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. So if we block that step, then we're going to inhibit the release of aldosterone. And that's going to reduce sodium reabsorption in the nephron. And because we reduce sodium reabsorption, we reduce fluid absorption, and thus will decrease our volume state. So because we decrease our volume state, we will reduce our preload volume, which is the amount of blood that's in the left ventricle before systole. So by nature, because we've reduced the amount of blood in the cardiopulmonary system, we will reduce the pulmonary pressure, and that's going to alleviate our pulmonary edema. Because ACE inhibitors block the breakdown of bradykinin in the lungs, you're going to get cough as a side effect in some patients. For some patients, this is manageable. Some patients, it doesn't happen at all. But some patients, the cough is not tolerable. And so in those patients, we're going to switch them to angiotensin receptor blockers, which essentially do the same thing, but they don't have cough as a side effect. ACE inhibitors are more tried, they're more dependable, but angiotensin receptor blockers can be used in patients that are having adverse effects to the ACE inhibitors. Hyperkalemia and hypotension are very rare from the ACE inhibitors, but I just put that here for completion's sake. As far as pregnancy, we're not going to use ACE inhibitors ever in pregnancy. It has a high adverse effect on the fetus. So you're not going to get a question asking about congestive heart failure in the pregnant patient. That would be way beyond the scope of USMLE Step 2 or even Step 3. You may get a question, though, on hypertension in a pregnant patient. So know not to use your ACE inhibitors there. You would use something else like alpha-methyl-DOPA. Okay, so this is where ACE inhibitors work, and you can see also where angiotensin receptor blockers work. So ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2, and they also block the breakdown of bradykinin. The loop diuretics, we tend to use furosemide, and what loop diuretics do is that they inhibit the NKCC transporter in the nephron. And remember what the NKCC transporter is it's in the thick ascending loop of the loop of Henle, and it brings in sodium, 2 chlorides, and 1 potassium. So loop diuretics block that, and because we block the reabsorption of sodium, we will reduce our fluid volume because we're causing a diuresis. So just like ACE inhibitors, this is useful in congestive heart failure for promoting the reduction in preload volume and thereby reducing the amount of pressure in our cardiopulmonary system. So this will reduce our pulmonary capillary wedge pressure and alleviate our pulmonary edema. Loop diuretics, because they are so avid on that NKCC channel, which inhibits sodium reabsorption, we can cause hyponatremia. Loop diuretics are also associated with gout and in very, 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 very rare circumstances, ototoxicity. But as far as ototoxicity, the number one thing you should associate with ototoxicity is aminoglycoside antibiotics, not loop diuretics. But know that this could be your bonus point on the USMLE if you know that loop diuretics can be associated in rare cases with ototoxicity. Like all diuretics, we do not use them in pregnancy. So the nitrates and vasodilators are also very useful in alleviating some of the symptoms of congestive heart failure, but they're not useful for reducing the mortality. And that's the same as diuretics. They don't reduce mortality. So what nitrates and vasodilators do is they promote vasodilation. And when we promote vasodilation, we reduce the blood pressure. And the way we reduce the blood pressure, when we cause vasodilation, we reduce systemic vascular resistance. It's much easier to pump something into a larger diameter tube than it is to pump something into a smaller diameter tube. So by reducing the systemic vascular resistance, we increase the stroke volume and reduce the pressure in the cardiopulmonary system. So you can probably see here that reducing the pressure in the cardiopulmonary system is really our goal in all of our treatments. So this is useful in congestive heart failure because it promotes an increase in cardiac output, and that's simply because you've reduced the systemic vascular resistance, so the heart doesn't have to pump against so much pressure, and so we're going to be able to get more blood out of the heart. The adverse effects of nitrates and vasodilators are hypotension and tachycardia, and these are both significant. So hypotension can be a very severe side effect of nitroglycerin and particularly nitroprusside if we have to give that IV in emergency cases. So by causing that hypotension, the hypotension itself is not really a huge problem because what the biggest problem from hypotension is falling down. As long as we're monitoring the patient and being judicious about our nitroprusside administration, we're not going to cause a severe hypotensive emergency. But what hypotension does is it increases the heart rate. And when we increase the heart rate, we increase the oxygen demand by the heart muscle, because they have to pump more, they have to contract more frequently. And so what can happen from that is that you can worsen ischemia. And so be very, very, very careful when you're giving nitrates or vasodilators, just because they do cause tachycardia, and that can cause a myocardial, it can cause myocardial ischemia. So you would see an ST depression on your EKG. You wouldn't cause a heart attack per se, but you would cause ischemia to the heart muscle, and that can be bad. So isosorbide, I want to point out particularly here, this is only given in the outpatient setting, and what it is a longer acting vasodilator. So we use this in the outpatient setting because it has such a long-acting effect. So if the patient doesn't have their nitroglycerin on hand, they'll still have some level of vasodilation. So we use both the short-acting and the long-acting. You can think of that kind of like how we approach asthma when we give them the short-acting beta antagonists and the beta agonists and the long-acting beta agonists. So we give them nitroglycerin, which is short-acting, and isosorbide, which is long-acting, in the outpatient setting. In the inpatient setting, we only give them nitroglycerin. In the emergency settings, we can use IV nitroprusside, as I mentioned, and then hydralazine can be used as an add-on in outpatient management as well. Beta blockers are going to be a staple of care in the inpatient setting and in the outpatient setting. It's not really useful for emergency cases because they take a little bit longer to work. And the ones we tend to use the most are metoprolol and carvedilol. So what beta blockers do is they reduce the heart rate, and you might remember if you've watched the MI slides that beta blockers are good for patients who have had MI. They reduce the mortality. Why do they reduce the mortality? Because by reducing the heart rate, you reduce the oxygen demand of the heart cells. On the other hand, in congestive heart failure, beta blockers reduce mortality for a different reason. The reason beta blockers reduce mortality in congestive heart failure is because by reducing the heart rate, you allow more time for the heart to fill up. You allow more time for systolic filling. And that's going to increase your left ventricular ejection fraction. And thus you're going to increase the stroke volume. So this beta blockers also have a vasodilatory effect, which also contributes to its effectiveness in congestive heart failure and the reduction in mortality. And so by administering beta blockers, you're going to reduce the systemic vascular resistance, and that also is going to increase the left ventricular ejection fraction and the stroke volume. So the way beta blockers work is they inhibit the sodium-potassium ATPase, and that will just slow the heart conduction system down. So beta blockers reduce the pulmonary capillary wedge pressure, as all of these drugs we use in congestive heart failure, and eventually that will reduce pulmonary edema. Note that I use the word eventually here. We don't give this in the emergency setting. I mean, you could give it, but it's not going to help much. Your ACE inhibitor and your nitrates are going to be the most helpful, and your diuretics are going to be the most helpful in the emergency setting. Beta blockers will be helpful later on in the inpatient setting and in the outpatient setting. So if you have a question on the USMLE that gives you an emergency case, a patient who is in respiratory distress, and we know they have congestive heart failure based on their chest x-ray, your answer is going to be ACE inhibitors and diuretics, and then your supportive care of nitrates, oxygen, and morphine. As far as for the outpatient and inpatient setting, then yes, you do add on the beta blocker. But remember that beta blockers don't help with our acute care of congestive heart failure for respiratory problems. They do reduce the mortality, but on the outpatient basis and on the inpatient basis, not in the emergency setting. So the adverse effects for beta blockers include hypotension, hyperkalemia, fatigue, and weakness. But really most of these are pretty rare. You can get hypotension from beta blockers in the first couple doses. Most of the reason this is because the patient notices it. But really I wouldn't worry too much about all of this. The adverse effects for beta blockers. Beta blockers are in general, they're very safe drugs. So in patients with asthma or COPD, you should remember to use metoprolol, or in other words, just don't use carvedilol. Carvedilol is a non-selective beta blocker, so it blocks both beta 1 and beta 2. Remember that beta 2 antagonists are going to cause bronchoconstriction. So that's bad in patients with asthma or COPD because those are obstructive diseases. So we want to use something that's specific to beta 1, not beta 2. So metoprolol should be used as the beta blocker because it's beta 1 selective in patients with asthma or COPD particularly. You can use carvedilol fine in patients that don't have obstructive pulmonary diseases. So our positive inotropes are dobutamine and digoxin, and we only use this in congestive heart failure. And the reason is because in systolic congestive heart failure. So the reason is because systolic congestive heart failure is a disorder of the pumping ability of the heart, whereas diastolic congestive heart failure is a disorder of the ability of the heart to fill properly. And so the diastolic congestive heart failure, you don't have any problem contracting, so we don't need to give positive inotropes. Giving them is only going to cause side effects. So there's no point in giving them for diastolic heart failure. For systolic heart failure, the problem is actually the heart's ability to pump. So we want to give positive inotropes because positive inotropes enhance your ability to pump. So we have dobutamine and digoxin, and the way positive inotropes work is by inhibiting sodium-potassium ATPase on the cardiac myocytes. So I want you to look here. Digoxin and dobutamine, for that instance, inhibit this sodium-potassium ATPase. So this is on the cardiac muscle cells. And so because you inhibit this sodium-potassium ATPase, you're going to block the export of sodium from the heart cell. So by blocking the export of sodium from the heart cell, we're going to increase our cellular concentration of sodium. We have this calcium-sodium exchanger. When we have a higher concentration of sodium inside the heart cell, we're going to indirectly block this calcium-sodium channel from working. This calcium-sodium pump is not going to work, and the reason is because if we have higher sodium in the cell, we're not going to have more sodium trying to come into the cell in exchange for calcium. So by increasing our sodium, we reduce our export of calcium. So indirectly, digoxin is going to increase your intracellular concentration of calcium. And because of that, we are going to increase our contractile force. Digoxin and dobutamine both do this. So we preserve our intracellular calcium, and that's going to increase our cardiac output. The adverse effects here are going to be digoxin toxicity syndrome or digitalis toxicity syndrome. That can happen in either of these, but we most often see it with digoxin because the patient takes this on an outpatient basis. So dobutamine is going to be initially used in both our emergent and inpatient setting, and then once we get the patient onto the outpatient setting, what we're going to do is we're going to transition them from dobutamine to digoxin. Digoxin is taken orally, it takes longer to work. Dobutamine is given IV, it works faster. So we want to transition them from dobutamine to digoxin while they're in the hospital, and once they're out of the hospital, then they're going to be on digoxin alone. So dobutamine for the emergency setting, dobutamine transition to digoxin in the inpatient setting, and digoxin in the outpatient setting because it takes a couple weeks for it to work. So digoxin or digitalis toxicity syndrome is triggered by hypokalemia. So let's talk about why that is first. So what happens is that digoxin competes for a binding spot with potassium. So remember that with our sodium-potassium ATPase, a sodium comes in here intracellularly, binds with our sodium-potassium ATPase. A potassium comes in from outside the cell, binds to the sodium-potassium ATPase, and then an ATP comes in, dephosphorylates, and then our sodiums get pumped out, 3 sodiums get pumped out, 2 potassiums get pumped in. So when digoxin comes along, it blocks the potassium binding sites. And because it blocks the potassium binding sites, it inhibits the sodium-potassium ATPase from working. So now think about it. If you have less potassium around, you're going to have more available binding spots for digoxin because digoxin and potassium are competing. So by having hypokalemia, you're going to increase the effects of digoxin. And so because we increase the effects of digoxin, it's like being in digoxin overdose. So this can happen for two reasons. It can happen because the patient is not getting enough potassium, so they're hypokalemic, or it can be because the patient has taken too much digoxin, so they're in digoxin overdose. Either of those are going to increase the effect of digoxin. But the more common reason is because you have hypokalemia. So the symptoms of digoxin toxicity syndrome most commonly are going to be hypersalivation, nausea, vomiting, fatigue, loss of appetite, and these very strange yellow visual disturbances, which patients will often describe as halos. If you've ever woken up in the morning and have that gunky sleep in your eye, and you look at a light, if you go into the bathroom in the morning and you see that kind of halo around the light, that's what it looks like. So severe symptoms from digoxin toxicity syndrome. So this is what we need to treat. If the patient comes in with or if they're in the hospital, or they come in with loss of consciousness, and then on EKG you notice bradyarrhythmia, and you know that the patient is on digoxin, then you should immediately treat them for digoxin toxicity syndrome. Another way you could see this on EKG, you'll likely see this in consort with bradyarrhythmia, is that you'd see a PR prolongation. So the time from the middle of the P wave to the R point in the QRS complex will be greater than 0.2 seconds. And PR prolongation can give rise to torsade de pointe, which is a life-threatening arrhythmia. So the way we treat digoxin toxicity syndrome, and let me just preface this, digoxin toxicity syndrome is rare, but that doesn't stop the USMLE from asking it, because they do like to ask questions of rare things. Sjogren's syndrome and Goodpasture syndrome are rare too, but that doesn't stop the USMLE from asking it. So the way we treat any kind of cardiac symptoms from digoxin toxicity syndrome is with digoxin immune fab, and this is also known as DigiFab, and that's what we administer intravenously, and that will bind our digoxin and hence reverse our toxicity. If the patient has a bradyarrhythmia, if they only have a bradyarrhythmia, then you can give them atropine, but it would probably be a good idea in any patient where you've diagnosed digoxin toxicity syndrome to administer magnesium because of their risk of developing PR prolongation and hence their risk of developing torsade de pointe. So we can give them magnesium sort of as a prophylaxis of going into torsade de pointe. So what I would do in any patient with digoxin toxicity syndrome, first know to administer digoxin fab. That's our first step. And then also to administer atropine for the bradyarrhythmia and magnesium for the PR prolongation and to prevent torsade de pointe. I would give it to any patient with diagnosed digoxin toxicity syndrome because their risk is so high. Lidocaine is another antiarrhythmic that can be given in these kinds of bradyarrhythmias. So the angiotensin receptor blockers are, as you remember, are substitution for ACE inhibitors if we need to. And the drugs that we use are losartan and valsartan, but candesartan and any of the other sartans are fine. So what angiotensin receptor blockers are competitive inhibitors of angiotensin II. So remember that ACE inhibitors are allosteric inhibitors of the ACE inhibitor, so they block the enzyme from working. Angiotensin receptor blockers are competitive inhibitors of angiotensin II, so they compete with angiotensin II for the binding site. And because they compete with angiotensin II, they reduce the activity of angiotensin II. And what angiotensin II does is it works in the adrenals to release aldosterone. So by blocking angiotensin 2, you block the release of aldosterone. And because you block the release of aldosterone, you reduce sodium reabsorption, and because you do that, you reduce fluid volume, because fluid comes in with sodium. The adverse effect from angiotensin receptor blockers are hyperkalemia, but we tend to not see this. And so let's go back to why digoxin toxicity syndrome is so rare. Remember that digoxin toxicity syndrome is triggered by hypokalemia. And a long time ago, back in the 60s and 70s, the only drug that we had to give patients with congestive heart failure were loop diuretics. So remember that loop diuretics cause hypokalemia. So we gave them loop diuretics and digoxin. And that was fine, but loop diuretics cause hypokalemia. Hypokalemia can cause digoxin toxicity syndrome in patients on digoxin. Now we have ACE inhibitors, we have angiotensin receptor blockers, we have, going back here to your beta blockers, these also can cause hyperkalemia. So because of all of this, your potassium is going to even out with the diuretic. So you don't have to worry so much about hypokalemia as a side effect from your treatment for congestive heart failure. If anything, you might be slightly hyperkalemic, but that's why digoxin toxicity syndrome nowadays is rare. But it's good to know about it because some of the people who write the USMLE were around back in the olden days. So, all right, so our last one, spironolactone, and this also increases your potassium level. What spironolactone is it's also a competitive inhibitor, but it's a competitive inhibitor of aldosterone. So what we saw here are we have ACE inhibitors, which are allosteric inhibitors of the angiotensin converting enzyme. We have angiotensin receptor blockers, which are competitive inhibitors of angiotensin 2, which reduce the release of aldosterone. And now we have something that blocks the action of aldosterone by blocking its binding site. So remember that aldosterone binds in the kidneys, and this reduces sodium reabsorption in the nephron and thus reduces fluid volume. So ACE inhibitors, angiotensin receptor blockers, and spironolactone all essentially do the same thing. They reduce the activity of aldosterone, but they do it in 3 different ways. Now with spironolactone, because it works right at the binding site of aldosterone, you have to be really careful because this actually can cause a very severe hyperkalemia. So this is the reason why we don't go to this drug right away. We like to use this drug as a second line if we have to use it, because you can cause severe hyperkalemia. So we have to carefully monitor our potassium levels in any patient when we're using this in the inpatient setting, and we really hate to use this in the outpatient setting. We do if we have to. We've got to make sure that we advise the patient of any symptoms that can come from their hyperkalemia, any changes in cognition, weakness, muscle weakness, particularly fatigue. So we want to make sure that these patients are very aware of the hyperkalemia that can come about. We want to keep these patients on a potassium-restricted diet. We definitely don't want them to be on any diuretics that are potassium preserving. So we want to make sure that they're on their loop diuretic. We want to discontinue if they're on any potassium-sparing diuretics like a Millerite or triamterene. We want to get them off of that. So very, 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 very important. Very important to know that severe hyperkalemia can come rise off spironolactone. And this is a second-line treatment. So let's talk about, and this is big on USMLE, they like to ask this, let's talk about what doesn't decrease mortality, about the drugs and treatment that we use in congestive heart failure. So first off, diuretics, or loop diuretics, or any diuretics for that matter, do not decrease mortality in congestive heart failure. They're great for treatment, they're great for symptom reduction, but they don't decrease mortality. Same with positive inotropes, digitalis, or digoxin, and dobutamine. Nitrates and vasodilators, again, these all reduce your symptoms, but they do not reduce mortality. And then the supportive care that we use in the hospital, 100% oxygen, nasal cannula, and morphine. Reduce symptoms, do not reduce mortality. What does reduce mortality? ACE inhibitors and angiotensin receptor blockers, beta blockers, and spironolactone. So these all reduce mortality in congestive heart failure. Why? I don't know. Just remember that ACE inhibitors, angiotensin receptor blockers, beta blockers, and spironolactone all reduce mortality. And that is the end of our pharmacologic talk on congestive heart failure.